and convene the special call meeting today for Monday, June 29th, 2020. It's 1:15. This is a meeting for us to talk about COVID-19. No action is being taken today. We will have an executive session associated with this. Colleagues, we tried to get as many people here as we could, potentially answer questions. Dealing with Dr. Escott and Stephanie. Dr. Hayden is with us. We also have Mike Pignoni from the university. We've been doing work on testing and testing strategies. We also have available Dr. Myers, who will be joining us at 1:45 to talk about the modeling that we have. Put some agenda items that these folks are able to discuss. The goal is to try to get information to you and leave as much time as we can for you all to be able to ask questions as best we can. And then I thought that it would be useful perhaps for us to talk about spending and whether at this point we think we have enough earmarked for the increase in rise that we have. As you all know, Austin's dealing with one of the greatest increases in infectivity of major metropolitan areas in the country right now. And as things are here with hospitals and the like, it's bad, but probably not as tenuous as it is right now in Houston and in San Antonio. So this is really coming to us in Texas. That said, I think we'll get right into it. I'm going to have Dr. Escott start, Director Hayden start. I'll let manager kick us off if he wants to. I think we have to get to Mike Pignoni relatively quickly because I think we lose him at 2. And the modeler will come in at 1:45. Spencer?
Great. Thank you, Mayor, council members, and really appreciate the opportunity for staff to provide an update on our health response to this pandemic. I want to begin by just thanking the health professionals that we have in our community. As you know, this is going to take all of us working together, and we've had incredible support from you as council and our entire community relying on the professionals that we have in our healthcare system. Dr. Escott, Director Hayden, and the countless of individuals that are working on this collectively as a system are going to be needed, and we need to rely on them in the future going forward. So thank you for that continued support. We also know that this is a marathon, not a sprint. As we see the increased numbers that the mayor referenced, we're going to have to make some tough decisions because we will not have the resources that are going to be necessary to accomplish and to accommodate all the needs that are out there. And so we'll continue to update you and get guidance from you on that additional direction as we move forward. We know that we all as a community need to take that individual responsibility. This isn't just about what government can do. This is about what our business sector can do, what our philanthropic sector can do, and ultimately what individual members of our community are willing to do to protect themselves and each other. And so we're all in this together, and I look forward to this conversation today. I'm going to first hand it off to Director Hayden, who's going to lead off our presentation, and then she'll pass it over to her Assistant Director. Director Hayden. You're on.
Hayden, you need to unmute, and it's good to see you back.
Thank you. Good afternoon. Thank you, Spencer. Thank you also, Mayor Adler. Appreciate the opportunity to provide an update this afternoon. We're going to change our format just slightly today. I'm going to provide an overview and then transition to Assistant Director Adrian Stirrup to cover the Social Services Branch and Homeless Services, and then to Dr. Escott. Our epidemiologists and surveillance last week, as you all were aware, our system was under maintenance, and it was under maintenance for us to add the case investigation and contact tracing to that system. The system was active on Friday, on the 26th, and our staff, we brought in additional staff to enter information to catch up on the data entry. We have started today with a shift of 2 teams to complete data entry. And so the system will now have the ability to reach out to persons immediately. The state's system, which is called Texas Health Trace, which is the state's data management system that will allow for a coordinated statewide approach to COVID-19 response. So the city of Austin has Salesforce as a system, and the state of Texas has Texas Health Trace. And so the goal with that system is across the state of Texas to have for a coordinated statewide approach. So all departments across the state of Texas, even if they have their own system, must enter all of the information in the system, along with other major municipalities because of the type of system we were putting in place. Several of us have other systems outside of Texas Health Trace. Our staff will continue to provide case investigation and contact tracing. So even with the automation that happened as of this weekend, our contact tracing staff will continue to call clients to ensure case investigation and process is successful. At the Emergency Operation Command, we have set up a testing group. This group ensures that all testing such as community site, target, cluster, pop-up resources, facility, and in-home testing occurs. Last week at our community site, we tested about 2,000 people. We have a contract with a company called I'm Aware to assist us with testing. So they are going to assist us with pop-up testing, facility, and in-home testing. Staff are in the process of developing a map of all testing facilities in Austin and Travis County. We are sending out a survey today to providers to get that information. Once we have that information, we are going to populate it and it will be on our website. Our goal is to keep that site as active as we can throughout this process. We are committed to having a testing strategy that is flexible and rapidly, and it will change to meet the needs of our community. So as we move along, we may have times where we are going to have to make changes to meet the demands in the community. Currently, as of July 6th, we will have 3 community sites that we will be working in, Givens, Dove Springs, and in the Rumberg community the week of July 6th. With our nursing home and long-term care, to support the nursing homes and long-term care facilities with support, as you all may remember, we have a testing recommendation plan. And with that testing recommendation plan, it allows us to work very closely with the nursing home and all long-term care facilities. Currently, we are providing protective information to 10 long-term care nursing facilities. Right now, we don't have any strike teams that are deployed as of today. We are in conversations with facilities that as they start to see more clusters, we will be working with them and to assess the need to provide additional strike teams. Since June 12th, our staff have also assisted with testing facilities. And in addition to testing those facilities, we have either provided swabs and swabbing assistance to 7 of those facilities, and others we have come in to provide the testing. Earlier this morning, you should have received a memo of the summary of actions taken by staff and partners this morning to address equity during this response. This is the first memo, provides a list of services from communication, outreach, and direct services to the Latinx community. We will continue with the process and have an event in July for African Americans, and then also a communities of color event. I will now transition the presentation to Adrian Sterrill.
Good morning. Thank you, Director Hayden. Just to pick up where Director left off, I'll share a few updates on the activities of the Social Service Branch. The Priority Populations Group has been working closely with other task forces within the EOC as well as with the GIST and the Equity Office to put together some of the strategies for the Latinx populations as well as other vulnerable populations. And so communication, I'll just go over the key points of that strategy. So the goals are: 1, to design interventions and solutions that are data-driven and solve for the most vulnerable. And 2, to ensure that equity is the focus in all phases of the response to COVID-19, including communication, testing, active surveillance, and recovery. And so when we look at our communication strategy, as Stephanie said, we're making sure that we're focusing on the needs of our bilingual populations. At this point, particularly the Spanish-speaking population. We're engaging 311 to assist us with interpreters to help folks fill out forms and direct them to resources. We're making sure that all of our media availability and our PSAs are in Spanish. We are supporting focused ad campaigns in Spanish, on Spanish radio and television. And we're also using social media to reach those populations as well, not only the standard platforms, but the more popular mobile apps. We want to make sure that this plan addresses language barriers and the digital divide. To that end, there will be a strong in-person outreach component. We're strategizing by zip code. And right now our focus is on 21, 23, 41, 42, 44, 48, 53, 58, and 60. We're really trying to be creative and use our community relationships, specializing at regionalized special grocery stores or ethnic markets. We're working with our places of worship. We've priced out a mailer campaign for multifamily complexes and apartments in those zip codes. We're reaching out to our parent support specialists in Austin, Del Valle, Manor, and Pfluger ISDs. We're going to strategize and use our community health workers, not only those that are internal to APH, but also those that are in places of employment with our community partners like Community Care, Del Med, El Buen Samaritano. We want to make sure that this strategy is ADA compliant. Thanks to Brian's leadership out of the Equity Office, we worked with the Economic Development Department to put out some messaging to our business partners about the barriers that the roping off of the front of stores may pose to people with differing levels of mobility. We want to stress community education. So as the messaging comes out from the GIST, from the Joint Information System, we want to make sure that we are leveraging our relationships in community and pushing those messages out using all the forms of media and strategies that I outlined before. And this strategy also wants to focus on community preparedness. We want to make sure that our community understands and can access PPE. We've been working with the EOC to work with our nonprofit and social service partners to make that available as the supplies permit. We're providing guidance to different agencies on the use of PPE and how to socially distance effectively. And we're working with different business sectors to provide them guidance on reopening. When the orders come out, how does that translate into their business? So we're really trying to have that boots on the ground reach in all of the areas that our communities are touching. Moving on to homelessness, I'll give a brief update on the Pro Lodges. All 4 Pro Lodges are still operational and at capacity with approximately 270 guests. Integral Care continues to provide on-site services at all Pro Lodges. DAC, Front Steps, Salvation Army, Communities for Recovery, and Integral Care are all providing housing-focused case management services. We're really trying to make sure that when anyone is exited from these facilities, that they have a plan in place. We're also working with Community Care and Del Med to continue the focused testing of the homeless population, both in our shelters and in our encampments. By now, over 500 tests have been administered in focused opportunities in downtown shelters and encampment areas across the city. We continue to work with HESUM and our consultant Haggerty on FEMA approval for reimbursement of all of the eligible pro-lodge expenses. Efforts to provide hygiene resources for our unsheltered neighbors continue. We have deployed mobile and stationary shower trailers, portable toilets, and hand washing stations. We continue to contract with Family Care and the Other One Foundation to operate our shower resources. We continue to distribute masks, toilet paper, hygiene supplies, and educational flyers, along with bags of food each week. And we continue to put up health and hygiene signs at each of our mobile basic needs stations around community, just to remind our unsheltered neighbors about how they can stay safe in their environment. We continue to partner with the Central Texas Food Bank to provide those shelf-stable meals for our unsheltered homeless neighbors. And we will continue to provide prepared meals through our contract with Revolution Foods, and that has been extended through the end of July as part of the Eating Apart Together initiative. Approximately $3 million in federal CARES Act funding has been allocated to the city, and we're working with our homeless consultants as well as our community partners on a request for applications to disseminate those resources into community. Moving on to our child care task force, we continue to provide support to our child care providers. We're in partnership with the Economic Development Department and NHCD on child care support funds. We continue to respond to questions and provide technical assistance to providers and summer camp operators. We continue to work with city legal on control orders and developing and updating guidance based on state and local orders. We're still working on our unaccompanied minor policy to figure out how we care for children whose parent might be in the isolation facility and do not have access to other family support services during that time. And I think that is all that I have. I'll pause there and pass it on to Dr. Escott, or if there are any immediate questions, happy to answer those.
Dr. Escott?
Thank you. I think Councilmember Kitchen had a question. Do you want to hold those questions to the end, Spencer, or you want me to go ahead?
Dr. Escott, why don't you go ahead and
Okay.
come back for questions?
Okay. Thank you, Mayor and Council. We want to give you an update on our current COVID-19 situation. If you could transition to the next slide, please. So this is a graph of our new confirmed cases. Again, the yellow is showing the 7-day moving average. We had another record over the weekend of more than 700 cases. You can see that our moving average of new cases has increased 372% since the beginning of the month. So that's roughly 5 times the current, or the rate on June 1st is what we're experiencing now. So you can see that yellow line is right about 400 cases on our 7-day moving average, as compared to around 60 on June the 1st. Next slide, please. This is our weekly confirmed cases, again, just showing you the breakdown by week. So the week beginning 6/20, ending on 6/27, recorded 2,539 cases as compared to 1,390 the week before. So again, almost doubling last week in terms of our number of cases. Next slide, please. This is an update of our graph on doubling time. So back on June 7th, we had our best doubling time at more than 44 days. And just 2 weeks later, we are close to 2 weeks. So right now it's at 16 days, which is a dramatic change in direction. And certainly that's reflected in our number of new cases that we're seeing. Next slide, please. This is a graph of our new admissions. Again, the yellow being the 7-day moving average of new admissions. Since June 1st, we're about 10 new admissions on that 7-day moving average. We've increased to more than 50, so we're at 52 as of yesterday. So again, a 400% increase in the rate of new admissions to our MSA hospitals since June 1st. Next slide, please. This graph is, again, an update showing you our hospitalized individuals in blue, the orange showing you our ICU patients, and the gray showing those who are using a ventilator. Again, since June 1st, a 214% increase in the number of hospital beds being utilized for COVID-19 patients. You can see that the rate of increase for our ICUs and our ventilators has not been quite as steep, which is good news for us. However, we are hearing from our hospital systems that individual hospitals are reaching occupancy for ICUs and are having to spill over into other hospitals. So hospital systems have identified hubs or specific facilities where COVID-19 patients are being concentrated. As those facilities reach capacity in their service lines for things like ICUs and ventilators, they are starting to utilize other facilities. So again, we have plenty of capacity right now, but these are additional signs that we are beginning to see additional stress in our healthcare system. Again, we've estimated 1,500 COVID beds available in the 5-county MSA. We're at about 350 now, so there is room right now. And I bring this up because we have folks who are putting off care, who are avoiding hospitals for urgent care and emergency care, and they don't need to do that at this stage. There is capacity at those hospitals. They can be seen in the ER. They can be admitted if they need to. There's room. But this is a warning for us that 2 or 3 or 4 weeks down the road, we may be in a much different situation, which is why we are continuing to sound the alarm to the public in relation to those protective actions that are needed right now to flatten this curve again. Next slide, please. This is an update of our graph on demographics related to hospitalizations in the last week. So you can see the numbers on the right-hand side of the image indicate the numbers from the last week. So you can see that our Hispanic population representation in the hospitals in our MSA have maintained steadiness at around 65%. Our white non-Hispanic is around 24%, so relatively steady. Our African American also steady at around 8%. So not a lot of changes in terms of the makeup of these individual races and ethnicities in terms of their percentage of hospitalized individuals. Again, this indicates to us a sustained problem in our community as it relates to disease transmission in our Latino community. And this is why, as Stephanie and Adrienne both pointed out, these targeted ongoing efforts to increase the awareness, increase the protection in these communities so that we can bend that curve as well. Next slide, please. This graph is showing you weekly hospitalizations by age group. I'm going to point out a couple of things here. The blue and the gray lines represent our 50 to 59 and 60 to 69 age group. You can see that both of them are near 20%. The yellow and the blue, the light blue and the yellow are representing our 20 to 29 and 30 to 39 age group. Those numbers have come down a little bit since last week, but again, because the hospitalization rate for those groups are much lower than the 50 to 59 and 60 to 69 age group, it is further evidence that the disease spread is primarily happening right now in that 20 to 40-year-old group. So again, We need those individuals to take more precautions, to be more aware, because as the numbers increase of transmission in that age group, so will the hospitalizations increase. And this is not a benign disease. This is not a simple cold or flu for many folks. For many folks, it leads to hospitalization and sometimes irreversible damage that's done to these individuals. So we've talked about deaths before, but it's important to understand that even amongst those who survive, they can have lifelong impacts on their normal day-to-day life, and that's certainly substantial as well, and we need people to be aware of that. Next slide, please. So this graph that I will show you first related to testing is just our Austin Public Health public enrollment testing. So you can see we have results back on more than 2,500 individuals. There's actually more than 3,000 tested through our public enrollment last week. Some of those tests are still awaiting results. Of the tests we have right now, we have a positivity rate of 9.6%. You can see the breakdown by ethnicity: 5.9% for Asians, 6.7% for white non-Hispanic, 11.7% for African American, and 15.2% for our Hispanic population through our Austin Public Health testing. Again, our goal is to be less than 10% overall and in each category, which tells us that we need to test more African Americans, we need to test more Hispanics in our community so that we can ensure that we have adequate surveillance in those groups and to bring down that positivity rate. So again, part of the effort that Director Hayden and Adrienne spoke about before was to educate folks about prevention, as well as to ensure that they're aware of how to get tested if they need it.
Did you say
Next slide.
10% or less than 5%?
Say again?
Less than 10% or less than 5%?
So the range that we're looking for is that 5 to 10% for positivity rates, so that we can ensure that we're broadly testing. We would love for it to be lower than that, but right now, if we can get each of those demographics to under 10%, we'll be in much better shape to control this. Next slide, please. So we have asked our partners in the community that are doing testing to provide data to us, and last week we started receiving that information. Some of that information is such a way that it needs to be cleaned up a little bit in relation to the cases, particularly the negative tests. So what I'm showing you here is for the test that we have a positive result on, this is a breakdown by race and ethnicity. Now you can see that 39, almost 40% of those results are unknown as far as the race or ethnicity. And that's due to a number of factors. Sometimes people do not share their race or ethnicity in the testing process. Sometimes the lab results that we receive in do not have a race or ethnicity assigned to it. So we're working through those issues to try to clean that up. I will say that looking at our Austin Public Health testing, that a significant portion of those who initially identified as unknown or refused to answer are from our Latinx community. So we are trying to clean up that data, but also want to encourage folks that when they're signing up for testing, that they share that information with us regarding race and ethnicity, because it's very, very helpful for us to make policy decisions when we have accurate information, and that includes that race and ethnicity. You can see that of the individuals who identify a race or ethnicity, that 32.7% identify as Hispanic, 23% white non-Hispanic, 4.2% African American, and 0.4% Asian. So again, this is a denominator of all the positive numbers for the last week based on that data feed from our partners. And again, we're grateful for them sharing that information. Later this week, we're hopeful to have a week-by-week trend based upon race and ethnicity for this larger data set. When we look at the numbers of testing done last week, when we look at our big three partners, that's Austin Public Health, Community Care, and Austin Regional Clinic, that number is around 11,000. So that's just those three entities. We have a number of other entities who are also doing testing, so that number is going to be higher. Again, as we have that reliable data feed from all of these testing entities, we'll be able to provide more accurate information as it relates to the numbers of tests being done, as well as the community-wide positivity rate. When we look at some national databases that have some automated feeds of this information from the major labs, it indicates to us that it reflects that Austin and Travis County have a positivity rate of about 22 to 23%, which is a number which was indicated by the White House last week in terms of a very high positivity rate in Travis County. I will say that two of the major labs that we use, which is CPL and AIT, are not part of that data feed. So those numbers may be artificially high. But again, as we get that information together, we'll report that based upon the data that we have in hand. I do also want to point out that that same data feed indicates that surrounding counties have similar or higher positivity rates, with the exception of Hayes County, which was around 15% the last check this morning. The highest being Caldwell County, with a positivity rate of more than 33%. So again, this is not just a metro issue. This is a statewide issue, and we have to continue to try to operate at least as an MSA, because this is affecting all of us. It doesn't matter where you live. It's affecting all of us, and the message needs to be the same, and it needs to be echoed around our community. Next slide, please. This is a breakdown of that same data set, which includes APH, Community Care, and our other partners. So we look at the percentage of positive cases by age. Again, you can see this week that the majority of cases are in that 20 to 29 and 30 to 39 age group. You can also see that that 40 to 49 age group has more than 15% as well. So again, this is where our target needs to be as far as messaging and outreach, is to ensure that that this group is receiving the message and taking appropriate precautions. I'm pleased to see that 50 and older is a much lower rate, or constitute much less of the positive numbers, because those are the ones who are both going to have a higher rate of hospitalization and a higher rate of death. So we need those folks in particular to be protective, to stay home unless they absolutely need to go out. We need the rest of the folks, particularly those in the 20 to 50 age group, to be protective as well, particularly if they live in a household with individuals who are in the older group or in other vulnerable groups within their household. Again, we have to continue to work as a community to protect the community, as City Manager Kronk said earlier. Next slide, please. This is a snapshot of the positive tests in the last week. So again, we can see that 78660, 78745, 78741, 78748, and 78702 were our top 5 for the past week. Again, we are working on a dashboard to enhance the testing information, as Stephanie mentioned earlier, I believe, and we hope to have some of this information front-facing in addition to the map that we currently have. So we are still working on that, and hopefully we'll have that in the near future. Next slide, please. This is an update in relation to our nursing home and long-term care facility testing, which includes assisted living facilities. You can see that we have 6 facilities that, sorry, I can't count, 7 facilities that are grayed out, which means if they have no additional cases next week, that they will come off the active cluster list. Unfortunately, you can see that we have had 30 cases in these facilities over the past week. So many of those are new facilities, or cases in new facilities, and that has been the result of an initial positive test, which has led to larger scale testing at those facilities. As Director Hayden said earlier, we have a task force whose only job is to manage these facilities, identify where clusters are happening, and sending out resources to support, including testing, PPE, and potentially the need for nursing home strike teams if it becomes necessary. So we'll continue to provide that update to council, and we're also working on a dashboard to automate some of this information so that it is public facing on a ongoing basis. Next slide, please. So I've got a couple of slides talking about some big picture issues, and as City Manager Cronk mentioned earlier, we've been sprinting for quite some time, and we have to ensure that the strategy we have in place and that we are moving to over the summer are going to be sustainable for a long duration of time. We certainly expect we have at least another year to deal with this, and in particular, until we have an effective vaccine which has been identified, mass produced, and available to the public. So part of that is testing prioritization. Now, I did have the opportunity yesterday to meet with the White House Coronavirus Task Force, including Ambassador Burks, as well as Commissioner Hellerstedt, Dr. Zerwas, and my colleagues from around the state. And we had some agreement on the fact that right now, the disease is spreading so quickly in an uncontrolled fashion that we simply cannot continue to do things the way we have been doing them. So that involves prioritizing, and that involves prioritizing testing. Part of that is because of limitations on the ability to collect enough tests, but more importantly, the ability of the labs to turn those tests around in a timely fashion. So what we're facing right now, as I mentioned a little bit last week, is that we are receiving positive tests back on individuals who were tested 5 or 7 or sometimes longer than that days ago. So if it's 5 or 7 days after the test was done, then it's 10 or 14 days after the person became symptomatic. So initiating case investigation and contact tracing for those individuals is a futile effort because their infectivity period's over. The individuals who had been exposed are likely already symptomatic. So right now we're prioritizing case investigation and contact tracing for those who have been sick more recently. In addition to that, we are having to change our testing priorities. So that includes ensuring that people who are symptomatic get tested first and get tested quickly. Those who live in congregate settings, those who are part of critical infrastructure, and those in our vulnerable populations. These still are our priorities. But what this means is that we are not going to be able to test through Austin Public Health and Community Care those who are asymptomatic. We simply do not have the capacity to provide those tests and ensure adequate turnaround times for those who are at the highest risk for being positive, and that's the list there. We are also in the process of discussing with other partners about transitioning some of the testing, more of the testing responsibility to private partners. As Director Hayden mentioned earlier, we have a contract with IamAware, and we're in the process now of working with our consultants at Haggerty to discuss transitioning more of the testing to non-governmental entities so that we can focus public health and public resources in other areas where only we can provide those services. As I said before, we're also having to prioritize and work on a structure to prioritize the case investigation and contact tracing. So let me explain a little bit about this. Case investigation and contact tracing is at the heart of public health intervention and disease investigation. But when we have widespread, uncontrolled disease transmission in the community at the rate that we're having it now, it becomes less useful for some of the reasons I mentioned before. So we really do need to prioritize those efforts where we can be most impactful in those areas that are being harder hit or where the consequences are more dire, such as in nursing homes or assisted living facilities. And certainly on those who had a more recent onset of illness, so that if we intervene, if we contact them and do their contact tracing, we have a better chance of capturing those who still would be at risk for spreading outside in the community. So again, we're having to go through a prioritization process. This is not just Austin. This is every jurisdiction in the state of Texas. And we've had regular communications with our partners at the major metropolitan public health departments, and they are having the same discussion in their jurisdictions. This is just where we are right now in this pandemic. One other thing that we intend to add on to this conversation is to engage the individuals themselves who are positive in helping us notify their contacts. Right now, they're asked to provide that information, and unfortunately, it's becoming more common that people do not want to provide public health in Austin and across the state information about their contacts, where they've been. So I think it's important that we engage them. If they're not comfortable sharing that information with us, we need them to share it with their contacts so that we can, again, inform those individuals who are at risk for having contracted COVID-19 so they can stay home, avoid infecting others, and get tested. So this does rely on a community effort, and it really requires all of us to do the things we need to do to get this under control so that we can have protection of public health and protection of our economy as well. We're working on enhancing messaging at the time of testing. As Stephanie said earlier, providing masks and hopefully some other equipment at the time of testing so that folks can protect themselves at home, continuing to advocate for the utilization of isolation facilities so that folks can separate themselves from their families to prevent that household spread, which we know is a major contributor right now to the spread of disease. So again, we've got to optimize our use of resources so that they can be most impactful right now. Next slide, please. So in looking at our needs, and again, this is part of the conversation that I had with Ambassador Burks as well as Commissioner Hellerstedt and the rest of the team, is that we really do need an integrated electronic lab reporting system. I spoke last week on the fact that we're still reliant on faxes to bring information in regarding positive results that then have to be transitioned to a digital format in order to initiate that process. This is not acceptable, and we need to move swiftly to have a statewide comprehensive system that's integrated with local health departments to achieve this mission. We've got to improve testing capacity and lab turnaround times, and we've certainly had that conversation with the state as well. Our lab partners are working on increasing testing. We also had a discussion yesterday regarding the importance of pooled testing. As we look particularly towards the fall and the opening of schools, we need to have the ability to test hundreds of thousands of people a day, potentially in our own jurisdiction, to ensure that as we open schools, we can do so safely. So I believe this is a priority for the White House, and that was certainly indicated yesterday in that meeting. We need to integrate local and state platforms for contact tracing and case investigation. Each of the local health departments have a platform. Ours is Salesforce. The state has a platform called Texas Health Trace. Those two systems don't talk to one another. And we are working with the state. I engage with Commissioner Hellerstedt and others to have that discussion. Is it possible for us to integrate these two things together to really broaden the efficacy of our efforts? And we're hopeful that we can have a ongoing conversation about that and really build that efficacy of that system so that we have a cross-jurisdictional system which is functional and robust. We've got to enhance the messaging to our teens up through our individuals in the age of 40 to 49 so that we can flatten the curve just amongst those groups where we're seeing the most spread right now. We've spoken about federal and state support for paid sick leave to remove the disincentives from going to work when you're sick because you need to have that paycheck to support your family. We need federal and state support for the distribution of masks publicly so that we can ensure that every member of our community has and protective equipment, not only when they go to work, but even inside their household, particularly when individuals are ill. And we really need a reassessment of the long-term strategy at the state, local, and federal level based upon the resources that we have. Again, as Spencer said, this is a marathon, and we need to better understand what that pool of money is going to look like going forward. We have some information regarding the end of 2020, but beyond that is in question. And we really need to have a better idea, because there are many different strategies that we as a public health department can utilize, but it's hard to do when we're not sure about the long-term funding. So far, we focused on temporary funding, temporary positions, but it's going to be challenging for us to recruit and retain temporary folks. We've already had a number of folks who started with Austin Public Health. They were offered a permanent position with benefits at other locations, and they're gone. We really must, at the local, state, and federal level, shore up public health, not for the short term, but for the long term. But doing so will give us short-term benefits. And finally, next slide, please. As Spencer said, we have to be this community of us, not just for COVID-19, but everything that we do. And if we cannot do this, we're not going to be successful. We are at the verge of having that recommendation come from me to the mayor and to Judge Biscoe that we close things down again. Right now is the time to act. Right now is the time that we all must make decisions, not just for us and our family, but for this community. And that decision needs to be, I'm going to stay home if I don't have to go out. And if I do have to go out to a public place, I'm going to wear a mask, I'm going to social distance, and I'm going to pay close attention to my personal hygiene so that we can stop this spread and flatten the curve again, as we did a few months ago. With that, I'll pass it back to you, Spencer.
Thank you, Dr. Escott. And I'll just note for the council and the community, this presentation has been placed in the backup for this agenda. And so if you want to have reference to these slides, you can find them there. I know there are many questions for the presenters so far, but I did see that Dr. Myers, our great partner from the University of Texas Dell Medical School, has joined us. And so with your permission, Mayor, we'll just go right into Dr. Myers' presentation, and then we'll open it up for questions.
That's what we should do. Dr. Myers, are you with us?
I am, yes. Can you see me?
No, can't see.
Can't see me. Let's see. Give me a second. You see me now?
I can, yes.
I'm going to try to share my slides, and then I'll get started. Let's see. Are you able to see my slides now?
Yes.
Okay. Can you still see it now that I've gone into presentation mode?
Yes.
Okay, great. So thank you for your time. Good afternoon, everybody. I'm going to share just a few slides that give current estimates for where we are today and where we may be headed in the next few weeks, and then follow up on my presentation from, I believe, last month, show you what things might look like if we enact the triggered policies that are now on the key indicators dashboard under different scenarios. So let me just start with kind of very, very short-term projections based on analysis we do on a daily basis to try to get a handle on how fast is COVID spreading today, how quickly are things rising in the community in terms of new hospital admissions and total number of hospitalizations in the 5-county MSA. So here are short-term projections using our estimates for the recent transmission rate. So we are estimating this from daily hospital admissions data, but because of the lag between the time someone is infected and the time they get admitted to a hospital, which is usually around 10 days, what we estimate today actually reflects how fast it was spreading about 2 weeks ago, week and a half ago. So based on those estimates, this is a projection for where hospitalizations are going. So the black dots there along the bottom go, I think, up to about maybe Friday of last week. And then we project from there using our models that are fit to the local data. Each one of those gray lines represents what we call a possible trend. Each one of those are equally likely to happen in the future. but you can see the mass of the projections climb sort of steeply upwards or continue to climb at the same exponential rate that we've been seeing over the last few weeks. And that black line in the middle is sort of an average projection, but it doesn't mean it's any more likely than any other projection. Importantly, these are projections assuming that behavior doesn't change, assuming that the virus continues to spread at the rate it's been spreading the last few weeks. If people very dramatically change their behavior, they wear face masks more, they take other precautions to slow transmission, or other policies go into effect that slow transmission, then we would expect to see these lines not climb quite as steeply and begin to slow in the coming weeks. So these are projections without any behavioral change. I'm going to add a line to this graph, which corresponds to our current estimate for hospital bed capacity for COVID-19 patients in the 5-county MSA. So based on these projections, although there is a lot of uncertainty, and you can see that there's some lines that never come close to that red line, that sort of mean projection is projected to approach hospital capacity and maybe cross it mid to late July. Now I'm going to show you a similar graph, but instead of showing you total number of COVID hospitalizations, I'm now going to show you daily hospital admissions for the 5-county MSA. So what you see along the y-axis here is not the single-day hospital admissions, but the 7-day average. And if you're probably aware that that is what we are tracking on a daily basis to figure out when it is that we should move into different alert levels. So the red dots in this graph are the observed number of daily admissions, again, probably up through about July 27th. And then the gray lines going off to the right are our projections. Again, the yellow area is the possible range that we are projecting going forward, the 95% range. Each individual gray squiggle corresponds to a plausible future scenario. Each one of those gray squiggles is equally possible. And then that black dashed line in the middle corresponds to sort of the middle, or the average projection. And again, these are projections without behavioral change. So this is assuming nothing changes, people don't become more cautious, we don't change our policies. And if things change, then these projections will probably no longer be accurate. And I'm going to add a line to this one too. If we believe that we are not able to slow transmission and we are really approaching at high velocity our hospital capacity, then our earlier models suggested that we probably should enact a stay-home order or do something to dramatically slow transmission around the time we cross a 7-day average of 70 new hospital admissions. And it looks like we could get there within the next couple of weeks. But again, it depends on the projection. Okay, and so this is sort of kind of current situation and short-term projections. Now I'm going to show you some longer-term projections, and these are much more kind of, you should think about these as plausible futures. It is very hard to project what COVID is going to do beyond a couple weeks because we cannot project behavior, we cannot project policy. So all of these are meant to be sort of if-thens. If we do this, then this is what we might see. So let me go into those graphs with that introduction. Okay, so this is what we might see if we are able to follow these staged thresholds that we have in place, the triggers that are now on the key indicators page. So this is assuming that we actually trigger at the thresholds that I'm about to tell you, and that people comply, that there's enough adherence that when we move to orange, we really do as a community slow transmission to the point that we would expect it to be slowed under orange. So the current projections I'm going to show you assume the following thresholds: that we move into yellow as soon as we cross a 7-day average of 10 new hospital admissions, that we move into orange when we hit 60, and 60 is we have a little bit of time before we get there, so we have a little bit of breathing room before we have to get into orange, but it has to happen pretty quickly. And then we would be able, if we really do move into orange and people change behavior and we slow transmission, then we can afford to wait until we hit 123 daily hospital admissions before we have to actually slam on the brakes and put down a stay-home measure. And in fact, the hope would be if we move into orange quickly, that we'll never get to the point where we need a stay-home measure. So this is a projection under that policy, again, assuming that we adhere. And so in this particular projection, so again, the black is sort of a middle line. It's no more probable than the lower gray lines or the top gray lines. And so you can see there's a lot of possible futures. But if we end up on the black line, then we expect that we will have to enact an orange alert within the next week or two. And if we successfully slow transmission under orange, we expect to be able to stay under that 1,500 capacity with 95% certainty and never have to go into a red measure, a stay-home measure. However, we will have to stay in that orange, that more strict state for quite a long time, probably through most of the first semester of the 2020-21 academic year. Now I'm going to show you projections, assuming that we are not able to go into orange immediately, that transmission continues at its current rate, and we do not we're not able to slow transmission either because we're not able to change the policies that really make a difference, or because we do change the policies, but people don't adhere and transmission continues at its current pace. So in that case, we may not be able to use these sort of partial measures to slow, to sort of tap on the brakes. And we may have to have no choice but to eventually resort to a stay-home order because hospitalizations are continuing at an alarming pace, and they look like they may soon approach our capacity. I'm sorry, I meant to mention, and we would project in this sort of 18-month horizon that there will be a little around 2,000 or 2,100 deaths in the all scenario. Sorry. So going on to the next projection. So imagine we're not able to enact orange for some reason, or it doesn't successfully slow transmission. Then we would, instead of being able to wait until we get to 123 7-day average of hospital admissions, we will have to slam on the brakes much more quickly, because as you saw, our hospitalizations are very fast approaching our capacity at the exponential rate that they're increasing. And then this is what we might expect over the coming months. If there's no choice except to let it spread like it is now, or be in a full-blown stay home, then we project that we will have to go through several prolonged stay home orders, the first of which will have to be enacted probably by mid-July. Again, these are possible projections, depend on behavior. Each one of those gray lines is equally likely. The black line is sort of a middle curve, and the red areas in this graph correspond to the periods where we would have to enact a stay-home measure in order to, and I'm sorry, that still says 1,400, but that's for 1,500 capacity, that line across the top. And in order to keep our hospitalizations under 1,500. So that's what it would look like, and that really looks pretty bleak, right? It's several months of periodic stay homes. And so, the hope is really that we can put in place measures to slow transmission that really are effective before we get to the point where we really have to enact a much stricter measure. And the last graph I'm going to show you is a scenario where maybe we can't get people to go orange right now. We're not able to, in the time that we have, really slow transmission in a way that changes this sort of very concerning rapid increase in hospitalizations. So maybe we will actually require a stay-home measure in the next couple weeks. So if so, what if after that we can put measures in place, put orders in place, raise awareness, so that when we're finished with the first stay-home measure, we really can go back into orange instead of just regressing back to yellow. And so in that way, maybe we'd only have to use one stay-home measure, and then after that, be able to kind of manage things with less restrictive measures. So in this case, there's 3 different triggers. There's a 10, a 50, and an 80. What you're going to see here is that we go into a stay-home measure in mid-July. It lasts 5 weeks, 35 days. And then after that, we go through about a 3.5-month orange period, and then we can start to relax things even further. So that's just another possible scenario. That's not all or nothing. It does require kind of really reining things in very quickly. But then if we can find a way to enact more or less restrictive measures that are indeed effective, maybe we can move into that kind of policy following the initial stay home. So those are the updates I have for you, and I'd be happy to answer any questions.
Just real quick, Dr. Myers, under this scenario, can schools open in the fall?
So under any scenario, The only scenario in which I would say that would be really, really impossible to have any schooling would be if we're in red, right? If we're in a stay-home order, we really are, we're really at a point where we really don't want anyone out and about. Under orange, orange is assuming that transmission has been reduced quite a bit relative to what it is today. So it is definitely possible that schools could be open in some capacity, but it would have to be with pretty extreme measures in place to ensure that that in-person schooling is not amplifying transmission. So the answer is yes, but extremely cautiously. And it looks like in this particular scenario, if we really do go into a stay-home order in mid-July in this particular curve, and it's 5 weeks long, we would be looking at going into orange about the time schools are scheduled or AISD is scheduled to start up for the fall.
Thank you. Colleagues, anybody have any questions now for any of the people that have spoken on anything? Mayor Pro Tem.
I didn't know if during limited time, because my questions are not for her, they're for Dr. Escott and Stephanie.
Any question you want?
Okay. So first about the contact tracing, I was trying to understand the faxing issue, and is that, who's faxing to who? Is it, I just want to understand what that whole issue is.
So Councilmember, currently receiving information regarding testing comes via fax. Now, sometimes that's email fax via fax, the email on ours, or the fax on our side is received via email, but it's basically being faxed from these facilities. So that's Quest, that's LabCorp, that's most of the major testing places, the hospitals. That's the primary method of transmitting information to all public health entities. In some states, there are statewide electronic lab reporting, which automates this process, which makes it more efficient. We have worked with our partners to generate some electronic feed. We are working to enhance that feed. However, in the short term, we have faxes coming in and we have the electronic feed, which still requires us to go through both to aggregate that information, determine if they're duplicates or not, if there are positives versus negatives, if they're Travis County or some other county. So it's still a very manual process, and I had this same conversation yesterday with the task force, and Ambassador Burks did mention that U.S. Digital Service is working on this. In fact, the U.S. Digital Service came to Austin to receive this feedback from us, and that was a request that we made from them. They are working on it, but this is something which may take a very long time to solve.
Okay, and then you mentioned the 3 partners that make up the pie chart of the positivity, and you said that there's 11,000, I didn't catch what that number was, 11,000 people have been tested from those 3 partners?
So those 3 partners I mentioned are Austin Public Health, Community Care, and Austin Regional Clinic. Those are just the 3 largest testers. There are others who are now sending information into us. But just from those 3 partners, there was approximately 11,000 tests done last week.
So last week?
Correct.
Just last week, okay.
Correct.
Okay. I thought that number, I thought you meant total, so last week. And then real quick, can you explain the pie chart that shows the percentages of by ethnicity and race, it has just positivity. So it had the Latino community at like 32% positivity, but can you explain but their hospitalizations are significantly higher. So I just want to be able to, and anybody watching too, to understand the different numbers there. So is it because even though the 32% makes up a proportionate number to the representation of Latinos, there's still more likely of that 32%, they have a higher chance of getting hospitalized and a higher chance of getting a positive test. Can you explain that whole relationship?
Yeah, so 2 things. First of all, the 32% underrepresents the Latino community.
Yeah.
Because a significant portion of the unknowns are also Latino community who chose not to provide information. And I say that because we've investigated just on our test, who makes up that group, and that's the group that we are also calling and doing contact tracing, so we have further information on that group to make that judgment. But also true is what you said, the Latino community has a higher rate of hospitalization as compared to those who are positive in the white non-Hispanic group. So both those things are true, and both those things are contributing to what we're seeing in the hospitalizations.
Okay, and then I have a couple questions for public health. Thank you, Dr. Escott. And thank you, you're right. I meant to say, even though that pie chart makes it look like we're letting them make it up less, it's not in fact the case. With regards to public health, there was 3 centers mentioned, and I didn't catch what they were, and one was in Dove Springs, and it was kind of a list of extra measures that were being taken. What are those 3 centers?
Dove Springs, Givens, and Rumberg were the three sites that we are going to start testing July 6th.
Testing what? Sorry.
We are going to provide mobile testing, pop-up testing in those communities.
Okay. And then we all got an email from members of the Latino Coalition, and there was a question about about specifically outreach because of the disparate numbers that we're seeing in the Latino community. A specific outreach plan, strategic plan, action plan for that community. Is there, and I forgot what it was. It was like it was supposed to be it was referred to as like, it's all we're talking about all the minority groups. Is there to be one specific for the Latino community because they are seeing such disproportionate rates of positivity and hospitalization?
The plan that was submitted to your office, to all of the elected officials' office, June 11th by Adrian Stirrup in my absence, was more of a comprehensive plan. The staff have, as a result of that, there were some measures in there that specifically targeted Latinx folks. And so we thought it would be important for us to put together all of the information that has been provided in this community as of today. And that information is in the email that was sent out earlier this morning. I'm not sure if you had a chance to look at that or not. The efforts actually go back as far as early March, according to the notes that I have, based upon when staff started providing some level of outreach, engagement, really a little of both. Staff are also working on another more detailed plan that we are going to work with partners to do that. And so that one will be more specific to that, to Latinx in particular.
Okay, and on that same, so I've seen the percentage of hospitalizations, positivity. Do we have numbers on like deaths? What the makeup is for people who have unfortunately passed away because of COVID?
Yes, we do. I don't have that in front of me. Dr. Escott, do you have that with your, I thought you had that with your information.
I don't have it on my presentation. I believe that's on the dashboard. We can make sure that that council gets that information.
Okay, and just because of the last point I'll make, it's not of a question, but seeing those projections, 2,100 deaths, and if all the disproportionate ways we are seeing this affect the Latino community in the 50s and above, I don't want to make any assumptions, but my assumption is it's about that 50 or above for the outcomes of deaths. And seeing that 2,100 number and thinking what that half of that is over 1,000 people, I just really hope we can focus on this community. Absolutely, it's affecting our minority community more than any other. But when we're seeing one particular group being so affected, I really would like our staff to, and I appreciate all the work that's being done. And as City Manager Kronk said, it can't just be the City of Austin. It's got to be everybody, all hands on deck. Everybody working together. But I think we really need to concentrate on this community that's being so affected. So let me know what my office can do to be available to help with whatever the strategic plan is. But we need something specific if we're heading into those very scary projections that we just saw. So those are all my. I have more, but I'll pass the mic. Thanks.
And to that end, Mayor Pro Tem, because I think you're absolutely right, the report that Director Hayden mentioned, working with the partners, that's the focus plan, strategic plan, I think we're going to see here in the next 2 days to that end. The dashboard does have the demographics by death, and it says that Hispanic is at 40% with respect to the deaths. Councilmember Cassar and Councilmember Kitchen.
I have some questions on the Latino community stuff as well, but I want to start with one for Dr. Myers. And Dr. Myers, thank you for everything you're doing for this community right now. A question that I have is, how do we make sure that if we're going to executive session here soon, I think we need to figure out how it is that even if we don't have permission, how is it that we can go back to shutting things down like we did in April? I hope that we get permission to do that. But one concern and something that we've seen throughout this is cities and governments acting too late. And I appreciate that your model has all of those gray lines on it, and then they kind of come together around one black line. But what I would hate is for us to miss the moment that we need to act. And so I would want to be extra careful. What if it winds up being one of those gray lines that's a little bit sooner? Or what if we take an action, but because, for example, we don't have permission, it is not as impactful in flattening the curve as what we did in April? So I guess my question to you is, should we be acting as if we're on your projected black line, or should we be acting like we're on one of the gray lines that's a little bit earlier just to be safe? I mean, I just would hate to act a few days too late. And I know that this is asking a lot of you and putting on you, to tell us what to do, but you just have been the best voice on this. So help me on how extra careful we should be. Should we be acting like we're on that black line, or should we be acting a few days earlier? What should we do?
Right, it's a $1 million question. I mean, the thing is that in some ways, we should already be trying to be in orange, right? Even though we've now bumped the orange up to maybe 50, maybe 60. I mean, there's no reason not to already be working our hardest to, within the rules that we have to follow, to get people to understand the risk, to wear face masks, to get employers to provide paid leave and other support so that people can stay home if they are potentially exposed. Education, everything. I mean, right now it seems like we should be doing everything we can short of a stay-home measure to slow transmission, right? Because we are definitely at that point. And if we're not at that point today, depending on which of those graphs you look at, we'll be at that point by next week. But we are at a point where we would like to be, tapping on the brakes in every way we can at this point. So, yeah.
Next question: the black line staying under 1,500. Did your triggers ensure that the black line stays under 1,500, or are you looking also at the universe of lines?
It ensures that 95% of those lines stay under 1,500. So no matter what line we're on, there is a 5% chance we're on a line that's alarmingly early and ends up, blowing by that line. But the way the math works is that the triggers that we derived sort of guarantee 50% won't exceed that line. And the ones that do, you can kind of squint and see these lines going above. They do go above, but they won't necessarily go twice as high as that line, but they'll, and we could be on one of those. And so, I mean, I think, we want to be doing everything we can now to get people to make decisions on a daily basis that protect themselves, protect their neighbors, protect their families, protect their community. I mean, I think, and I know I'm not directly answering your question, right? So if it looks like people are not slowing things down, well, should we err on the side of like, let's go into a stay home at 50 rather than 60 or rather than 70? And I mean, that's I don't know. It's hard to know. It really depends on the community's risk tolerance. It depends on also what we assume. Like, do we believe that if Austin is given the authority to enact a stay-home measure, that it will be immediately effective, right, at really slowing transmission, or do we actually think that once you enact a measure, it'll maybe take a couple weeks for it to for people to adhere and to know? I mean, so I think there also might be reason to act a little bit earlier if you think that there's some inertia in the system that's going to take a little time to overcome. But that's as close as
I think that answered a lot. So if basically what I'm hearing is if our order or any order, be it from the governor, be it with the governor's permission, be it without, is as effective as it was in April, and we act based on the triggers you've laid out, then 95% of your future worlds stay under that line.
Yeah.
It's not that 50% of them do and 50% don't. It's that 95 of them stay under that line. Is that right?
Yeah, that's right.
But if our order or any action we take to go into red is not as effective as in April, then there's a whole different assumption you'd have to put into your model.
That's right.
And that's the worrisome piece, is that we need to make sure that whatever we do, first of all, it'd be great for us to not have a stay-at-home order at all and everybody to do the right thing. But if people don't, then this is really contingent on people following whatever it is we do.
Yeah, and let me just say one other thing, which is that these triggers and these projections are all based on two goals, right? One is we want to minimize the amount of time we're in a stay-home order, and avoid it if at all possible, and we want to, if at all possible, prevent our community from having an overwhelming number of hospitalizations that exceed capacity. Right, but nowhere in these analyses is additional goals of let's just try to minimize deaths, let's just try to minimize hospitalizations. Right, this is a very specific kind of optimization problem. And if we take measures now that are orange-like, that are doing better at cocooning high-risk populations, that are doing better at protecting our Latinx communities, that are doing better at protecting other vulnerable subpopulations, there are going to be other collateral benefits of that, right? We may just be able to bring down exposure in vulnerable populations, bring down overall hospitalizations, reduce deaths, et cetera. So these thresholds are really specifically tailored to do one thing, which is the minimum amount of restrictions to avoid exceeding hospital capacity. And I imagine that there are other goals at play as well.
That's helpful. Thank you. My next question is, oh, sorry, go on.
Sorry, Councilman, I was just going to add, and thank you, Lauren, for that summary. This is why we've built the alternate care site. This is why I recommended to the city managers that we initiate the process of activating that alternate care site to give us a buffer. What if one of those 5 gray lines is the line we're on, and we need to have that extra capacity? That's what that's for, if we overshoot the mark. But let me be very clear, we do not want to utilize that facility. We do not want to care for people outside of a hospital if we can avoid it. And that really does take all of us making changes now. I don't think there is any one of us, and probably there's not anyone in the community that wants to see us shut down again. That's why we have to have those people act now. That's why we are staying in orange right now. But we can't just be in orange in theory. We have to be in orange in practice, and we've got to get this community engaged in that. It takes all of us. And as Spencer said in his opening remarks, we cannot do this alone. This problem is much too big for government to do this alone. It has got to be all of us. So we need folks not to wait for public health or Austin or Travis County or the state or federal government to do it. they need to have those conversations with their family members, with their friends, with their community groups, because we need that action now.
Dr. Escott, I don't know if it's you or Director Hayden best to answer the question. Earlier this week, I guess last week, we don't really know what weekends are anymore. But a few days ago, we were getting more communication from constituents than I'd seen before of people that were symptomatic that couldn't get a public testing date within a week. I hear the changes that it is that you've shifted to. What is our goal as far as symptomatic people, how quickly they should be able to get a public testing date if they're a person who cannot afford another option? And where are we now?
Yeah, Councilmember, I want those people to be able to be tested within 2 days, so that within 3 or 4 days, we can have a result back. But let me say very clearly, in the circumstance that people cannot get a test, because we could be there, right? Our rate of increase is increasing very rapidly, and it's going to be hard for us to keep up with testing. In any circumstance, if you cannot get tested and you have symptoms which are consistent with COVID-19 right now, you must assume that you are positive. You must stay home. You must protect yourself, and you must protect your family. You cannot wait on a positive or negative test to take action. We really do need everybody to do that. Again, and I said this last week, we really do need folks who have the resources to get private testing to do that. We need them to go to Austin Regional Clinic or to their private practitioner or one of the many resources in the community that does testing. If they have insurance, the test is still free for them, because we need to focus our public resources on those who have no other means for testing. So thank you for bringing that up. And again, we need ongoing messaging about that as well.
And I think that brings me to one of my last points for this time, which is also in the last few days hearing from more and more constituents who, and these are primarily folks in the Latino community, who an employer said, when is your test scheduled? Would let those folks off of work to go get their test and then say, and come right back to work when you're done getting tested, which is against the mayor's orders. It is people who are sick and feeling sick, getting sent to get tested and then being brought back to work. And those constituents said, I was going to get let off of work if I get a positive test result. These are people who are symptomatic. So that's what's happening in our community right now. And we just need to double down on our messaging to the business community to let employers know that that isn't acceptable. And I think at our testing site, we've been in conversations with APH, but I really want to emphasize at our testing sites, or when we do contact tracing, whatever we can do to make sure that people stay home, that when they come to the testing site and they're symptomatic, that we say, you're going home after this, right? You are not going back to work. And if somebody isn't getting paid, we have to find a way to get their employers to follow the federal law and pay them, or for us to find a way to keep them home, because that is overwhelmingly, I think that is a big thing that is happening in the community right now, given people's lack of access to sick time, even though more and more of those folks do have it based on the federal law. So I just want to emphasize that what you just described right now, we're hearing already from people that they're getting called back to work straight from the testing site.
Yes, and Councilmember, that's a plan. It's just not a very good plan. And we do need people to have a good plan. And when I think about the reopening process that we had in Texas, and we see that it's not working out well, and we've got to learn a lesson from that. And certainly a lesson, if we have to shut down again, that we need to take stronger steps before we reopen. And I'll just point to, what our sister city in Adelaide, Australia did in the state of South Australia. Before businesses could open, they had to go to the state website. They had to put in their business name, the square footage of their business, and describe their plan. And that plan had to be approved. That plan included information for contact tracing that the business owner maintained. So if there was cases, that case contact and case investigation could be done. We've got to have businesses have a stronger plan than that. We've got to have everybody engaged, and that includes our business community. I'm thankful for the work of the Austin Chamber. They have been sharing messages, but unfortunately not everybody is in that group. Not everybody's engaged as they need to be. And so we're going to reach out to them some more so that we can continue to advocate, and so that all businesses really understand the importance of their decision-making in terms of contributing or improving the rate of spread that we have right now.
And we need to make sure that message is getting to those Spanish-speaking workers in particular and targeting those folks. I just heard from the folks at Seton that 63% of their recent COVID admissions are Spanish speakers. So not only do we have the disproportionate number of Latinos, but 2/3 of it is Spanish speakers in particular. So I appreciate that focus. That's all, Mayor. Thanks.
Okay. Councilmember Kitchen, then Councilmember Harper Mattis, and Councilmember Ellis.
Okay, can you hear me?
Yes.
Okay, so I have three different sort of categories of questions. So the first question I think is, I'm not sure who it's for, but I think I saw on one of the slides that, my question is about what we might be able to do in 78745, because I'm not sure if I heard that area as one of the areas that we can provide some assistance for in particular. And I think I saw that it was one of the top 2 areas on one of the slides for additional infections. And so is 78745 on the list for the next, one of the next ones to be considered some focused outreach? I mean, that is one of the areas. I mean, GAVA works with 4.4 and 4.5, and there are some significant parts of 4.5 with Hispanic populations. And so I'm just wanting to make sure that 78745 is on y'all's radar screen to add targeted outreach for those areas.
Yes, it's on our list. We're actually, GABA was going to send some additional information, so I need to reach out to Corman because she had a list of information she was going to send me, and she may have tried to send it while I was out. So I'll circle back around. Yes.
Okay, so is it safe to assume that that particular area, 78745, and I think part of that's in Mayor Pro Tem's district, part of it's in mine, and maybe part of it's in Councilmember Renteria, but so y'all are working on to see what you can do in that area. Is that what I heard?
Yes.
Okay. Okay. Let's see. Then second question is, and so I'd like to follow up, and I'm sure my colleagues in those areas would like to follow up too with you on Stephanie, so we can get a more definitive idea of what could be done in that area and when. So, okay. Then for you, I think this is for you, Director Hayden and Dr. Escott. I want to step back for a minute, and I know that you guys have all been doing just an amazing amount of work with the resources that you have. And so I want to ask about this from an infrastructure perspective, from a staffing infrastructure perspective and a public health department infrastructure. I want to know how you all are thinking about what your needs are to actually carry out all these things that need to be done. You had mentioned, Dr. Escott, I think on one of your slides, about rethinking of local strategy. And my question relates to local strategy related to staffing infrastructure and the way the public health is working, or perhaps there's a need for additional consulting help. So can you speak to that for me? Have y'all thought about, have you thought yet about what you need from that perspective moving forward?
This is Stephanie. I think I probably should address that for Dr. Escott. Yes, the team has, we have initially met with a consultant, and then the consultant met with the executive leadership team. And the goal is that we're going to provide a plan to City Manager Crunk at the end of July about what the department would look like. Because we know that this is going to go on, We don't know how long, but we know it's going to continue. And so as we're looking at, things changing and, once we shift back and the city starts to open up, the plan will include kind of setting up a management structure. And so a team is working on that. So we will have more information specifically about what that looks like. So absolutely, we are in initial phases of that, and we'll be working with a consultant to finalize those plans.
Okay, I'm glad to hear that. There's public health, just from my perspective, our public health department and our public health infrastructure is something this council has been working to build over the years, and I can thank the Mayor Pro Tem for a lot of her early work in that area. But we know that there's more that needs to be done in a good year. And now that we're confronted with COVID, there's much more that we need to think about in terms of our public health infrastructure. So I want to encourage you all. I'm glad to hear that there's a plan for thinking through that. And City Manager, I'm glad to be here and you'll be thinking about that. I want to ask you to bring to us as a council, if you need to, what's needed in that area so that we can be sure and address it. I wouldn't want there to be a situation where you've identified what needs to happen, but then you've hit a brick wall in some areas, because that is something as a council we want to be a partner with you on to make sure that happens. So then the last area I wanted to ask about was the nursing homes. So thank you, Dr. Escott and Director Hayden, and I think it was Assistant Director Sturp that reported on that. I think that the recent nursing home report, which was a report on the first phase of completing the first round of testing for all the nursing homes, was very helpful and also very hopeful, I think. So, and I think I heard you say, Dr. Escott, that there's been some work started now with testing in assisted living facilities. So I wanted to confirm that I heard that correctly. Can someone tell me whether the testing in the assisted living facilities has begun?
Yes, the testing has begun. We have we've tested 8 new facilities.
Okay, and so I assume you have a plan for proceeding with the remaining ones. Is that right, or?
Yes, what our staff are doing right now is because we are continuing to follow the plan that we have for long-term care. Mm-hmm. And so our staff are going to send them out a survey to have an idea of exactly what they can do on their own to test mm-hmm. their entire facilities. Mm-hmm. And this is the same thing we did with the nursing homes as well. So okay. With the trying to determine if they're able to do their swabs or do they need assistance with swabbing. Some of them just need the swabs themselves. So we're working on that process. And so in the meantime, as cluster cases come open, we'll continue to test in that space until we have a final idea of what that would look like. Okay. And thank you, Dr. Escott, I think, for mentioning the dashboard on the nursing home data. I can see on the COVID website under clusters, for anyone who's interested, that you've got the first information up from last week. So I'm glad to hear that the work is happening to update, to get that more updated. So I appreciate that. And then the last question was related to the one of the slides that showed the I think it was the positive cases by age. Does that slide include the nursing homes? Do you know which one I'm talking about?
Yes, it includes all the testing data that we've received in from our partners, including okay. Austin Public Health.
Okay, so it would include those. So okay.
Correct.
All right, thank you.
May I comment on her 4-5 comment real quick?
Okay.
78,745, I'm sorry. 78748 was also in that like top 5, which is also, we share that. So I'm wondering if there's a spot between the 45 and the 48 that's a shared area that if you're looking for locations, Director Hayden. Because those two touch each other.
Thank you.
Okay, thank you. Councilmember Harper Madison.
Thank you, Chair. I appreciate it. Thanks to all the experts on the line. I wanted to start with Dr. Myers. There was you said something along the lines of, you talked about the degree of uncertainty, but then you said something along the lines of, if we enact policies that make a difference. And I just wonder if you have specifically in mind, what are you indicating there when you say make a difference?
So I mean anything that actually effectively slows transmission. So and I don't know, it's hard to know what is fueling all the transmission in Austin. There's things you hear about, like people going to bars, people going out, younger people not wearing face masks, but also you imagine there's probably like what we heard a little bit earlier, people whose employers are asking them basically to work while they're likely infected and infectious. So I mean, I think there's this virus is spreading in a lot of different ways in a lot of different communities in Austin. So it's any measures that we can take to slow transmission in all dimensions. So if people actually do wear face masks, if they actually are given incentives and support that they need so that they can stay home from work, if they don't feel well, or if they think they've even been exposed to someone else in their household or otherwise who's infected. So, any steps we can take, and then certainly, taking extra measures to shelter vulnerable populations, including nursing home populations, other older individual members of our communities, and younger people who have known underlying conditions or lack of access to healthcare, et cetera.
Okay.
Council member, I just also wanted to add, I think it's important for us as a city to identify what we can do to dial things back. Because what we're trying to do right now is dial things back so we don't have to dial things off. And so I met with Parks today and Director Hayden and made the recommendation that we close our non-chlorinated pools. Barton Springs or Barton Creek and Deep Eddy, because that is a place where people congregate. That is a place where we see the target age group behaving in such a way which is not protected. I think we have to identify those areas that we as a city we know we can control our programs, our space. So we have to do what we can. We need others to do that also. Businesses, restaurants, how can I dial things back, still keep things functional, still pay the bills, but dial things back so that we don't have to dial off. Because in any circumstance, if we have to dial off, we're all going to be hurt by that. So I think it's critical, as Dr. Myers said, to identify those things that we can meaningfully do to turn things down. I will say in conversations with the state yesterday that I think that the governor is increasing in his flexibility to do what needs to be done, to either direct MSAs or to dial things further down or dial them off, or allow the local governments to make that determination. I think the state sees that we've gotten ourselves into a situation that we cannot maintain. So I'm hopeful that local and state can work together to really find that sweet spot. How can we get things back in a situation that we can control it, where we can test people who need to be tested, where we can contact trace people who need to be contact traced. And then in the future, when we reopen or open things further again, move back to a higher stage of reopening, that we find a better path to do that.
I appreciate both of your answers, and I'd like to just say on behalf of my colleagues and I, if there's ever any sort of, because oftentimes we're operating off of the information that we're gleaning from you, we're extracting what we can from your presentations, but if you have something explicit if you were able to enact X policy, we would be able to prevent the spread of by way of, I think that would just be so helpful if that's ever the case. And I do find that oftentimes the information is presented in a way that it can get a little vague. And I can understand the difficult position you're in, but certainly you can understand the difficult position we're in as well. So as much as possible, I'd love to really get like explicit guidance. So perfect example, here's one that would be difficult and nobody would want to have to say the words, but something we recognized was problematic during the course of the last shutdown were the problematic parks. Like really just saying, these are the 11 parks where people congregate too much. Turns out as a municipality, we need to shut parks. So if we were to have that conversation and the truth was, you all as the experts leaned in the direction of that being the appropriate course of action, it would be great to have that, sort of support to be able to make the difficult decisions. But with that, I have just a few other questions. So speaking of hard to reach populations, a meeting that I'm having this week is with some folks who are from the various communities that make up our like African diaspora communities. And one of the things that they're working on doing is just getting empowered as communities to independently go through the, dozens of dialects to be able to communicate to folks. I'm looking to figure out, and I guess this is probably an APH question, in addition to you, Dr. Escott, looking to figure out how we can help to empower those communities more. It's certainly not a question I'm asking right now, just put it out there that my office, and I'm certain some of the others, District 4 has a lot of folks from the diaspora as well. I saw that Pflugerville was on there leading the charge in terms of transmission. That's the highest concentration of folks from the mother continent, in which case I think that's another conversation when we're talking hard to reach populations that to date I haven't heard anybody make mention of. I think there's some assumptions about African community and African American community, and certainly we all recognize that we're not a monolith. So just wanting to make sure that we're addressing those communities as well. And so I'll be in touch with some ideas I have and really looking to extract whatever ideas you all have for how we can empower those communities.
Before you go on to your next question, I'll come right back to you. We're going to Dr. Myers now. So does anybody have any last questions for Dr. Myers before we thank her and let her get back to Dr. Myers? Thank you very much for the time that you spent with us. I'd point out with respect to Dr. Myers' work, we've seen two models that let us open up schools in the fall. And both of them require us to really be able to do orange really well, which is everybody masks, everybody social distances, no big groups. And one scenario has us doing it right now, in which case, if we actually did it right now, we could open up schools in the fall. Or we can't do it right away, and we have to psych ourselves up to actually have the discipline, in which case we have to do, and our numbers continue to scream here for another week or two, in which case we have to do a red shutdown for 35 days, but we could tell people at the beginning, this is not open-ended. We're going to do this for 35 days, and at the back end of 35 days, we have to religiously mask everybody and social distance. Dr. Myers, thank you for giving us both of those scenarios. Thank you for your time.
Thank you. Take care. Bye-bye.
Bye. I apologize, Councilmember Harper Madison. You can.
No worries. I think these are APH questions. I heard during the course of the presentation something about a map timeline or about the newest sort of maps that we're going to get. I was just wondering what the timeline is on the completion of that.
We just sent that survey out today. Our hope is that we will get all the results back this week, at the end of the week. And we hope to have something about the weekend if we get everything in. And we know we're going to have to make changes to it as we get new sites. So we'll continue to update it.
And just to be clear, you said Givens, Dove Springs, and St. John's, correct?
Givens, Dove Springs, St. John is where our testing site is.
She said Runberg as a third one.
Frostburg. Okay,
Yes,
thank you.
yes. Mhm.
Can you explain how those sites were selected?
Yes, they were based upon the data that we received, our current data that we have right now, as well as ensuring early on, we've had in conversations with community members based upon the data, and then the conversations that we've had with community participants wanting to see if we could start in those areas. And this is just the beginning. As I said earlier, and we will be planning some additional sites, but we wanted to go ahead and get moving. And then we change as we go along. That's where we're going to start, and then we can change as we move along.
I, for one, am very happy to see that there's finally some movement there at Givens, and especially seeing, you know, that O2 is in the top 5, and that's right in the heart of O2. So I'm really excited to see that that's happening. One of the other things that I heard during the course of the presentation was how some hospitals are at capacity. I'm curious to know which hospitals those are.
Councilmember, that's not information that we share publicly.
Okay.
Because there's constant shifting, and we really do want the hospitals to have the freedom to shift resources. I'll say that the cooperation we have with our hospital partners is really remarkable. And even across the systems, they are sharing information, sharing resources. We have a commitment from all 3 major hospital systems that if one system runs out of ventilators, the other system will either send them to them or accept those patients into their facilities. So we want that ability for folks to move around resources, move around patients as necessary to care for folks. Again, right now, we have capacity. We're going to have capacity for, you know, looking at the projections, at least another 2 or 3 weeks. So we don't want the public to think that there's not room for them if they have something going on. It's about what's happening in 3 or 4 weeks from now that we get concerned about. And we don't want to approach that 1,500 line and risk not being able to take care for people within the walls of the hospital.
So my last 2 questions are, during one of the presentations, I heard that Caldwell County is upwards of 33%. Where do those people go for treatment? Are they coming to Austin, or is there another closer regional hospital that they're going to?
Councilmember, I don't know specifically about the Caldwell County cases. I will say that, you know, the Austin MSA, particularly Travis County facilities, service a much larger jurisdiction than just the 5-county MSA. We are where people come to when they're ill. We are where rural hospitals will send folks when they become sicker than they can manage. And you know, it's hard to say where particular people are going. There are other hospitals. You know, there's a hospital in Marble Falls. There's some other smaller outlying facilities that folks may choose to go to outside of the MSA or outside of Travis County. I will also say that Caldwell County had a much smaller number of tests. So again, it's hard to extrapolate the 33%. You know, I think they tested 30 people last week. But the important message is that this is not just a metropolitan issue. And I think because of the numbers in the metropolitan area, that people get the false impression that, oh, well, I live in the country, or I live in a rural community, I can't be affected by this. That's a city problem. That is not the case. This is an everywhere problem. This is a worldwide problem. And regardless of where we live, we've all got to follow those guidelines of the masking, the social distancing, and the personal hygiene.
This might be a tall order. I just wonder if it would be possible to sort of see numbers by county and then hospital resources in terms of proximity. Just, it would be helpful to sort of map out in my mind's eye, if for no other reason, to make certain that we're advocating for appropriate resources to come to our hospital facilities in Austin. If we're servicing outside of the 5, then, I think the resources should reflect the populations of people we are actually serving. So just to put that on your radar. The last thing I'll ask is, we were talking about testing facilities, drive up. So I've heard through the grapevine that you don't have to drive up. You can walk up to the testing facility. I just want to make certain that that is in fact the case. If for no other reason, we can share that information with folks who want the most accurate information. I think that's an awesome public question.
Our current test site at St. John's is drive-through only. So let me explain a little bit about that. Major part of the reason for doing that is because the car and the windows serve as protection for the testers. And the way that was built out, the personnel, the PPE usage was optimized by having people in cars. The programs that Stephanie mentioned are different. I'll let Stephanie answer the question about those.
The other pilot sites that I've talked about earlier in the community are going to be, you would have the ability to walk up to those sites. And then I think the other thing that Dr. Escott didn't also mention is community care has set up where folks can either drive or walk up to those sites as well. So that may be the other piece, because there are several others that are testing.
So Dr. Escott's response built on the second half of my question. The second half of my question there was, I had heard early on about taxi vouchers and rideshare vouchers and options for people who are carless to go to drive up testing. Just wanting to see if we still have that system, if it's up and running and robust. And if that's the case, if the window serves as a barrier, I just wonder how we reconcile a person being in a car with a driver who's not a family member, but having the swab and exposure. That it brings on more questions and answers for me about transportation assistance.
So currently, I'm not aware of any rideshare or cab that is willing to do that. We have had some circumstances, I believe, where EMS has in the past had to help with that because they have larger vehicles and they can isolate the driver from the person being tested. But this is why we needed to identify the resources for walk-up testing or home testing, so that we can provide a different option for folks who can't access that drive-through appropriately.
Director Hayden, I'm sorry. Would you correct me if I'm wrong? I thought, several weeks ago we talked about transportation assistance. Was that exclusively for people getting transportation to the clinic, being dropped off, and then returned home? Or because I may have misinformed some members of our community if there is, in fact, not transportation assistance.
I have to apologize. I was not here 2 weeks ago. Let me see if Adrian Stirrup was on the call. Unless it was during the last meeting.
It might have been 6 weeks ago. All the weeks are the same.
Yeah, they are.
Good afternoon, if I may. This is Adrian Stirrup. With respect to transportation, what we were able to get our partners to assist with is transportation for non-COVID related rides. So to the grocery store, to the pharmacy, to any other non-COVID medical appointment, but not for testing, which is why we have been strategizing around these pop-up sites and other opportunities for people to test.
That is very important information. I was definitely misinformed. I've made some assumptions. So there is, in fact, a need for us to. Okay, yeah, that's neither here nor there. I think that was all of my questions. Thank you very much.
I think you're muted, Mayor, but I think I read your lips to say my name. I wanted to extend the conversation a little bit more about testing availability and the percent of positivity rate. So I know you had said it, Dr. Escott, but I wanted to give a little more space to what happens when we have ample testing available and people are able to get it quickly, and when we don't have ample testing, and how that relates to percent of positivity with the 5 and 10%. Can you go into a little longer detail about that?
Sure. So there's the availability of testing in terms of people to do testing and the test collection kits. There's availability in terms of space for the labs to do the tests. And there's availability in terms of rapid turnaround times. And if you don't have all three of those things, then testing becomes less effective. Remember that we're testing not for the purpose of identifying somebody so we can give them a treatment, as may be the case with flu. We're testing for the purpose of isolating and contact tracing and boxing it in. So if we don't have all those elements together, then we lose the effectiveness of that testing strategy, that boxing in strategy. In that circumstance, we have to scale back so that we can identify those who are the most likely to be positive, ensure that they get testing first, or those where having that answer positive, negative may be the most impactful, such as our communities of color, such as nursing homes, jails, and other congregate settings. And that's why we've had to prioritize those individuals so we can ensure that we have the timely turnaround so we can impact this disease.
And I think it's important to note that if you want your percent positive rates to go down, you need to have a lot of testing available so that you are able to figure out who's negative and who's actually positive and needs medical attention or needs to self-quarantine. When you don't have enough tests, then you're only testing the really urgent cases, and then you're going to see that positivity rate go up. So if you actually want less positivity rates, you need more tests, not less. I think that's an important distinction that people need to understand. And I know that you said it, I just wanted to give a little more time in this discussion to that important distinction. And I also appreciate, on another topic, you mentioned discussing, it's probably with the Parks and Recreation Department, about non-chlorinated pools. And I appreciate knowing that discussions going on. I and my team have been having conversations about some of the greenbelt entrances, like the Hill of Life and the 360 access point, because when other pools and other sources of entertainment for our community are not available, those places are being overcrowded. And it's become a serious issue that we've been working on for a number of weeks. Director McNeely with Parks and Recreation and her team's been working very hard, as well as Director Spiller and the Transportation Department. And so I wanted to make sure you knew we want that to be part of this conversation. I would like it to be part of the conversation because people are treating open access spaces now like they're the pool options. And I know it's getting hot out there, but with the graphs and charts that Dr. Myers showed us about how important our behavior over the next 2 or 3 weeks is, that is a really important conversation. And I would love for you to be involved with Parks and Recreation in those decisions. My office is happy to help too. Dina in my office has been working extremely hard with neighbors in the community to try to address this situation. And I think that needs to be wrapped up in these conversations as well. But you also had mentioned about bed capacity numbers. And I think early on, we were given a number closer to 4,000 beds. Can you talk about the difference between 4,000 and 1,500 beds and what that means for hospital strategies and our community as a whole?
Certainly. So the 4,000 number was total beds available. That includes those beds that can be used for COVID and those that can't. So what are those that can't? Those that can't easily be used are things like labor and delivery beds, pediatric beds, psychiatric beds, those that are not easily converted to care for COVID patients. And the rest of it outside the 1,500 are those where we have to have capacity to care for everything else. So heart attacks, strokes, traffic accidents, everything else that folks get hospitalized for, we still have to be able to provide. And that's where that 1,500 comes from. That's the capacity that we think we can dedicate for COVID patients without substantially impacting those other patients.
It's important to note on that number, and as you knew last week, there was a lot of conversations, Councilor Ellis, about what numbers were capacity and the like, and the governor had numbers. What we went to the hospitals with, and we said, give us a planning number, because they pointed out correctly that we're not going to really know the answer to that until we're there. So how many more beds you need is in part dependent on whether there's a flu outbreak or not, or all these other things. So at best, you're hoping for a bell curve. Maybe they get help from an affiliate hospital in Michigan or something like that. So you can't really be sure. What they gave us was their best assistance on what an appropriate planning number would be, and that's the number then that we gave to them.
And I appreciate you mentioning that, because I think that's important for people to know, that the definition of what beds available for what is kind of depends on the needs as time goes on.
And Councilmember, there is consensus in the discussion with the task force yesterday and with my colleagues across the state. The consensus is the beds and the space are not going to be the issue. It's the people to provide care for those beds that is going to be the issue, because those people have to come from somewhere. So we are going to be relying on nurses, physicians, others who can be flexed into the hospitals or into the alternate care sites if we have to use them. That may mean military personnel need to be requested to help staff hospitals. Because remember that as we see uncontrolled, widespread community transmission, that's going to hit nurses, it's going to hit doctors, it's going to hit respiratory technicians, it's going to hit paramedics and EMTs and firefighters. So that's going to further impact our surge capacity. And those things are taken into consideration. And I'm grateful that our hospital partners have worked those. What's the expected number of people that may be out at any one time that can't staff this bed, so that we can better prepare for the future?
I appreciate that. That's a really important part of this conversation, because sometimes I hear the discussion around, why should I wear a mask? I'm not worried about myself. And it really is a matter of protecting the doctors and the nurses too, and protecting people on the front lines who work in grocery stores that make sure that we can keep our households going. And so much about wearing a mask is actually about how much you care about those around you, and even those in your own family that you may be quarantining with. You may inadvertently give something to them. And a lot of the conversation needs to be around how we are protecting each other as a community. So I really appreciate that line of thinking and reminder as the weeks do go on. I have one last question, and I'm not sure if it's for Dr. Escott or Dr. Hayden, but I had a question around childcare centers. So the ones that are able to operate or are helping the essential workers, how is notification working with childcare centers? We've talked a bit about nursing homes and what kind of regulations and information that can be given out about the people who are in nursing homes or the people who work in nursing homes. But I'm curious, because we got news recently that there was a child care center in my district that was showing some positivity rate, and this was in the news. And so I was just curious if you could daylight, are there state regulations around that notification, or who is entitled to the information if they do find that someone in a child care center has tested positive?
As you may know, the state of Texas also regulates child care facilities. And so those regulations are provided by the state. However, Austin Public Health staff have been providing some technical assistance, typically with the weekly report that typically comes out on Friday afternoon with the non-cluster reports. You'll see that industry would be listed there if that has been a site that we've noticed. In the past, we have put childcare facilities on there as well. And it's the same type of process as we have for any other business that has a cluster of 3 or more by providing that additional technical assistance. The other thing, just as a reminder, we've been able to provide some hygiene type of kits to them upon request. And so they have been reaching out to our staff to get that additional cleaning supplies for those facilities if they need it.
I appreciate that's helpful, and I don't have any more questions.
Okay.
Thank you.
Does anybody else have any more questions associated with this, these folks that have come and spoken? Councilmember Tovo.
Yes, thanks so very much, all of you, for this information. I have a couple of quick questions. Firstly, I think Mayor Pro Tem Garza said it well, that reducing, I shouldn't try to summarize, but in any case, I think you made the point, Mayor Pro Tem Garza, that it really can't just be the city, that the community has to be a participant in this. And I just wanted to thank the Austin Hispanic Contractors Association for all the work they're doing to communicate with their members, and to they were the recipients of many masks that they were able from Jonathan Kunz's foundation that has gotten masks to so many organizations. But I appreciate the really good work that the Contractors Association is doing to help get the message out among the individuals they represent. And so I agree, we really need to rely on our community partners to help us really reach individuals throughout our community who are most at risk. And my staff and I will certainly be looking for opportunities to communicate to some of the younger members of our community who reside within District 9, including those on West Campus and elsewhere in District 9. I wanted to ask about a couple quick things. First, I missed one point. I'm not sure if it was my connection or on your end, but I didn't understand, and I think this question is for Director Hayden or her staff, when the contract with Revolution Foods has been extended through. I missed the end date.
Good afternoon. That contract has been extended through the end of July.
Thanks so much, Assistant Director Stirrup. We know that there are additional food needs. I know that the AISD caregiver program has been extremely helpful in reaching out to the parents and caregivers of students within our school district. They've extended their student meals through the summer, and likely the money that we allocated by council resolution will not be able to stretch through that same period. And so I wondered if you could help me understand, and this may be a question for the manager, whether our approval of the spending framework, as long as there's additional funding contained within the spending framework under that category of food assistance, whether that's something that you, manager, could go ahead and authorize absent further council vote to allocate more funding to that particular need.
Thank you, Councilmember. As you know, this is an ongoing discussion we'll have with our providers, and based on the need, we'll continue to, if we're not able to do it on our own, but I think we have that authority to do so, we'll be raising those to the council for further direction or further decision-making, but we will continue to update you as we get more information.
So I'm sorry, I somewhat followed you, city manager, but not completely. So if there is additional funding, we approved a spending framework that had about $1 million beyond what had already been allocated, as I recall, for food needs. So we know that there will be additional costs associated with that contract for Revolution Foods, which is absolutely necessary. We know that there are additional needs for those caregiver meals, possibly others. We don't meet as a council, or at least at this point, we're not scheduled to meet as a council again until late July. Do you have the authority you already need to make additional allocations in those areas if you deem those the highest priorities among food needs? Or would you need another council vote?
Not at this time, I have that authority, but I will make sure I'm updating council as appropriate. And so I'll be getting with staff to provide a real-time update on what those needs are, and then lifting that up to council as well.
Okay, I appreciate that. Thank you. I was just trying to figure out what the path forward would be to elevate that need. I'll just put in my own strong urging that we do fund some, provide some additional funding. And I also just want to say thank you. Jason Alexander sent out a link that shows there is also a private effort to raise funding for the student portion of the meals. And so, I would encourage those community members who are able to contribute to those community-based assistance programs to do so, because we do have such a need for food. Of course, not just among the students in AISD and their caregivers, but in other areas as well. And that brings me to my next question. I wondered if someone on the call could provide us with a status of the caregiver meal program in Del Valle. Last I heard, it was still it was not up and running yet. There were still contract negotiations going on, and so if someone has an update about that, that would be helpful. Or maybe after.
Good afternoon, council member. Yes, let me check staff and get the most up-to-date information, and I will respond back shortly.
Okay, I appreciate it. Thank you. Or I believe, could you please cycle back to something we talked about earlier and tell me what the status is of our isolation facility? I missed what the total occupancy is. You gave us the occupancy for our pro lodges, but it wasn't clear to me whether our isolation facility is at full capacity or not.
I do not have that information in front of me, but I can get that for you as well.
Thank you. And so if there is, can you remind us who is eligible for the isolation facility?
The isolation facility is available for those who are confirmed positive, those who are persons under investigation or waiting on a test result, and those with a known close contact exposure. So if individual is a household member or had a close contact and they live with somebody who maybe or may themselves have a high consequence or high risk of serious illness, they can isolate themselves there as well.
Right.
So yeah.
So a roommate would definitely qualify. We did.
Yes.
Okay. And as far as you know, they still have capacity within the isolation facility?
Yes. Last time I checked at the end of last week, we had around 70 individuals there. It was a significant increase from the prior weeks, which was averaging around 20. We have done some significant outreach and work with the media to improve the use of that, and I'm happy that it's increasing. There is still plenty of capacity there.
That's terrific news, and I know that we can find information about how to get in that queue or how to get that referral from the COVID website at austintexas.gov. So I will go there for that information. If people are aware of, I was made aware of a situation where a close contact is aware of an individual who has COVID-19 and is continuing to work. What suggestion would you have for that person? Is that a 311 call? Is it a counseling that individual to go to the isolation facility? Are there any official mechanisms that you would suggest beyond just trying to have a conversation with that individual about the safety issues at risk and the resources available?
Yes, Councilmember, it's again, it's up to all of us to try to reinforce one another's protective behaviors. So certainly starting there is what we'd like. Individuals who are positive or who are close contacts are issued an order from me, which requires them to stay home. There is the potential for legal action If there's a violation of that, there's a criminal offense and a fine. And we also have the ability to go to a court for a court-ordered quarantine if that becomes necessary. But again, there are so many people who are getting infected right now. We obviously don't have the ability to enforce all of them. And so we really do rely on that step one, which is having the conversation, the reinforcement piece.
But thank you. I think it's a good reminder that there are legal actions, as you said, that can be taken. Oh goodness, I had one last question. Oh, I know, this was for, so we did get an email today. Thank you for getting the word out, Austin Public Health, about the need to make sure that even during a time like this, family members are making sure that children within our community are getting the kind of preventative care that's so necessary in terms of vaccination and other things. I know my family went out last week to get up to date on our well checks and our vaccinations. We had delayed them a bit, and it was time to get everybody up to date on that. But I think it is. I would ask you just to address that. I assume, since you sent this out, that you want people to remember that it is a high priority, and it is a high priority even at a time where we're encouraging people to stay home for non-essential reasons. And so I wondered if you could just address those two issues together, why it is still important to seek that preventative care, and why the confidence that you have in our medical facilities to make sure that they're managing risk well for their patients, that is, when we're telling people to please stay home if you're able to, it is not from that kind of preventative care visit.
So
I had to, and I'll just personalize it. I mean, I asked that question of myself. Is this the time to go seek that care, or should we delay for another period? So, if you could just kind of speak to the parents like me who are kind of weighing and balancing those choices.
You bet. Right now is the optimum time to go. As I said, there's plenty of spaces in clinics. There's plenty of spaces in the hospital, in the ER right now, for folks who need to seek care, in particular, those preventative services. Back in March, those places were starting to close down, not because there was a danger in contracting the illness, but because we didn't have enough personal protective equipment for hospitalized people and for the first responders. So we really had to concentrate that PPE where we really needed to have it. Now, PPE is more broadly available. There are procedures in place, including symptom screens and temperature checks when people come in, separation of those who are sick in waiting rooms versus those who are well, and generally speaking, getting rid of waiting rooms. So, people are waiting in their cars until it's time for them to come in. They check in. They're the only one in the lobby area. They check in. They go back to a room. So the clinical services, the hospitals and the clinics as well, have done an excellent job of taking the principles of social distancing and hygiene and modifying practice, just as our businesses have done. So it is very safe for folks to seek care, and they really must get that preventative care done. We've talked before about not only the importance of immunizations at preventing those diseases which may be prevented by immunizations, but also, when we look towards September, when the new flu shot comes out, it's going to be critically important that we have a better immunization rate for flu than we have ever seen before, because we cannot tolerate a COVID surge and a flu surge at the same time. There's just not enough capacity. So I really would encourage folks to get that preventive screening done. And, one other thing I want to mention is, when we think about health and whether or not we are healthy or not, we often think about how we feel. And let me just say that it's not about how you feel. It's about really if you're healthy or not. And I bring this up because we have so many in our community that either don't have access to primary care or have not accessed primary care, that don't know that they have clinical obesity, hypertension, heart disease, diabetes. So not knowing you have those is different from not having them. And it is really important that if you have those things, that you get those treated now. Because, certainly it's of great benefit in the long run, but in the short term, you're better off in regards to COVID-19 if you have diabetes and it's managed, or if you have hypertension and it's managed, rather than those things being unmanaged and now you have COVID-19.
Thank you. That's very helpful.
Hello, this is Councilmember Alta. I have a question. Can you hear me?
Yes, Councilmember Alter, why don't you go ahead?
Thank you. So I really appreciate the great clarity on the ISOFAC and the protective lodges, et cetera. But I wanted to better understand what we are telling people when they go for testing before they get their test results. This builds a little bit on what Councilmember Kassar said, but it was a concern that I had going in here. What are we telling people when they go to get a test before they get their test back, knowing that there is a delay of several days? As I understand it, they don't get their order unless they test positive. And yet we may have significant spread happening if they are going about and not quarantining themselves.
So they're given similar instructions before the testing, if they're symptomatic in particular, or if they have an exposure. That's if they're signing up through our Austin Public Health public enrollment, there's some electronic information that they receive as part of the package that they're going to receive in the future. They receive a written document, a flyer in English and Spanish, with instructions again, as well as they'll also now be receiving masks so they can protect themselves and their family, particularly in the circumstance where they can't use the isolation facility. Again, we really encourage folks to utilize that facility. It's a free hotel room, food, Wi-Fi, TV, and that really is our best way that we can separate folks and prevent that household transmission. I can tell you that folks shouldn't be scared about that. We have folks from city and county government whose families have had to isolate in those facilities because they've been exposed, or they themselves are utilizing the isolation facility to separate themselves from their family. We've seen healthcare workers use it. It's not frightening. It's a hotel. And it's available. We are certainly talking to the state about helping us support additional facilities should we need it. And it can be just a rolling process. As we fill up facilities, we'll move to the next facility. On that note, I do have an update. We have 95 occupants right now of the isolation facility, and that's out of 246 total capacity.
Dr. Escott, then we also have another facility that we have on standby, or is that being used as a protective lodge right now?
We do have the ISOFAC 2, which is on standby should we need it.
Okay, thank you. And then I wanted to go back to your discussion with the Parks Department. Could you speak about other recommendations you had beyond the pools about what changes to openings in the park system that we might need to consider? Particularly concerned about basketball and what we're seeing in our parks about, games with 10 plus folks in very close quarters with no masks, sweating and breathing all over each other, right in the age groups that are of most concern. And are we considering whether that is a cause for spread?
Director Hayden and I had a great conversation with Director McNeely regarding parks and pools and what we can do to further dial things down. And I think now's the time that we have to continue those conversations. It was a brief conversation this morning, so we need to have more conversations to look at some of those details and identify those particular things that are happening on city property that need to be mitigated further. And, I think, she and her team are also going to continue to look at best practices from other locations to learn how we can do things even better. Quite frankly, right now is not the time we can take a lot of chances. Right now is the time that we need to err on the side of being a bit more aggressive on the dial back so that we can avoid the dial off. And I've had a similar discussion with the city manager and with other departments. I think we all have to think about what is it that, within our departments, the services we provide that may pose a risk because of congregation in particular, that we can dial back or dial off temporarily until we get control.
Thank you. I understand that there's been some changes for county parks in the run up to July 4th. Are there any plans for changes for our parks for that? That'd be my first question. And the second question is probably for the city manager. Understand that our park system's under a lot of stress. How are we making sure that they have the resources they need to meet the extra needs that are happening in the parks? Thank you.
So again, we had that discussion with Parks this morning. I've provided some recommendations. I think there's some further discussions that need to be held to make a determination of dial down versus dial off in a timeline. But I will say that I'm quite concerned about this Independence Day weekend and the risk that it may pose for large congregations. And let me be very clear, because this is important. Again, the city can only do so much. We could turn things off, turn things down, limit the activities on city space, but that could mean that folks go somewhere else and congregate in other areas. And I know we want to celebrate. I know we want to get together with our families. I know we want to have fireworks shows and barbecue and do the things that we normally do. But now's not the time for that. Now's the time that we have to be strong together by staying home, by doing things within our own household, by watching the fireworks on TV. I know it's not exciting. I know it stinks. But that's what we have to do right now, because we are in a very, very dangerous spot. And if we have those activities happening this weekend, this may accelerate things in a much faster way, and we just cannot take that chance right now.
And I was, Council Member, appreciate this line of questioning, because it is really important that we look at all of the ways in which we can lead as example from the city enterprise, including some of the restrictions that you may have remembered from back in April, and even what we did for the Easter weekend holiday. So we're looking at all of those, and we'll have more information for you shortly. And regards to your second question on the resources for parks, I'm in constant communication with ACM Shorter, who's talking to Director McNeely, and very aware of some of those constraints that they have, and we'll be continuing to provide the resources that they need to maintain their operations.
Okay, I appreciate the attention that you're both paying to those issues, and appreciate all the work that you all are doing under this very difficult circumstances. Thank you.
Me. Okay. I had very similar questions about the parks. Why haven't we closed them? I mean, all the modeling specifically said, unless we drastically change behavior, we are heading towards some really scary numbers. And I feel like we have to do what, I guess everything's anecdotal, but just because, like, I don't know, why is Barton Springs still open? And why is, it's not even a chlorinated pool? And I get the concern about, well, then they'll just go somewhere else, but maybe they won't. And maybe if we send the strong message, don't leave your house, don't go anywhere, that's the message that is in fact heard, because it's not just about, spreading it at the location you end up at. It's that if you're on your way there and get in a vehicle accident, you're taking public safety resources off the grid, so to speak. You're taking, heaven forbid it's something bad, you're taking a hospital bed off the grid. All those, going to Barton to the grain belt. I remember making several rescue calls there of people falling over a cliff. And, it's just, I don't understand why. I get it's a tough balance, but I feel like we have to control the things that we can control. And believe me, I've gotten tired of jogging around my neighborhood, but I will continue to jog around my neighborhood because I don't want to go to the, run on the trail. Why aren't we closing those places?
Thanks, Mayor Pro Tem. And unless Dr. Escott had anything else, I'm going to ask ACM Shorter to provide additional context on this ongoing discussion they're having with the Parks Department.
I have nothing else, Spencer.
Great. ACM Shorter? You're still on mute.
Well, if there's technology issues, I'm happy if we can get maybe some further, but I know that we're going to start getting those questions a lot, especially as we head into July the 4th, because I'm on the inside and I get all the information. I have no desire to go anywhere on July 4th, and it's because I feel like we need to get everybody else to there. Like, we don't need to be going anywhere. I'm just going to say what my other questions are because I know we're running out of time, and so part of this was to also ask, I hope we're going to continue doing these. I thank you, Mayor. I reached out to the mayor and thought it was important for us to be able to have this information because we would usually get them during work session, and we're not having work sessions right now. So I really encourage us to have these regularly, especially as we see these numbers rising. So with that in mind, I had questions about. I've heard that community care, you cannot get tested there if you do not have an ID, and that can affect some in our undocumented community. I'd just like to get some clarification on that. Not now. Questions about if there's any discussion about a second stimulus package from the federal government, where we are, maybe that's something we're going to do in executive session. RISE funding update and any other help update on how much of that money has been allocated and what communities it has helped, because I've heard a lot of misinformation on what have gotten part of that. And that was it. And just, I think it's important for us in these meetings.
Thanks. And we do have ACM Shorter if you want to chime in just briefly.
Yes, I am on the line. Spencer, thank you very much for taking the question, and Councilmember for asking. I'll say quickly that we are absolutely, as Spencer mentioned, in conversations, and we're talking earlier this morning about making a quick decision. We will likely be releasing and announcing information about the status of our parks for the holiday weekend, really in the next 24 to 48 hours. That includes those pools that are not chlorine pools. We'll include those in the announcement. I'll just remind the council that the park system, including our trails, is a very important component for mental and emotional health during these times. So we like to sort of make sure that we're drawing the proper line in terms of making sure that we keep the community safe, but that we also offer opportunities for our residents to get out of their home and safely recreate.
Okay. Thank you. Councilmember Flanagan.
Thanks. Yeah, I just want to agree with what the Mayor Pro Tem laid out. I too have been getting tired of running through my neighborhood, and definitely not just running back and forth to the kitchen from my home office. So I appreciate what you had to say, Mayor Pro Tem. But I am also hearing from some of the neighborhood leaders in my district that neighborhoods that have their own parks systems, neighborhoods that have their own pools that are for their communities, and the longer the city keeps hours open, the harder it has become for them to do the right thing by their own residents. I think it's really clear that we should be really erring on the side of caution as the city because it sends the message to the public. And I also am seeing today that finally mayors in Williamson County are starting to join and put mask orders on in their communities. I really wish Judge Gravel would do the same thing for the whole of Williamson County, since there are still parts of the areas adjoining my council district that are not incorporated into any city. But I'm glad to see Mayor Van Arsdale in Cedar Park and the city council in Round Rock move forward on their own mask orders. But I would definitely encourage you, Spencer, and all of our staff to very much err on the side of caution, because it sends the message that the private owners of these types of facilities need to know what they need to do to protect the community as well.
Okay. Mayor Pro Tem, you asked one question I think needs to be responded to here. You do not need a government-issued ID at community care in order to be able to get testing. I think that their website might say that. If it does, it's not accurate. People should bring something, best if they had something that had their picture on it, but they're letting people take tests even in the absence of that. Further questions? Councilmember Harper Madison? And remember, we have an executive session when we're done here too.
I will. So I just wanted to say briefly, just for the record, apparently folks without transportation can call the Austin Public Health Nurse Line to schedule at-home testing. I know a lot of folks are tuning in with us right now, so just wanted to make sure that that was said on the record.
While we're doing public service announcements, the hospitals have also asked if you've had the virus, please, there's a real significant need right now for plasma, for blood donation, for people that had that. At one point, we had 20 times what we were using every day, and now we have the exact amount that we're probably going to use on a given day. So we have a great need for people. If you've had the virus, please consider donating blood, plasma, so that can be used. Councilmember Tovo, then Councilmember Ellis.
Sorry to backtrack us here a bit, but my staff and I were not able to find on our COVID resources on the website the number that individuals should call if they need to access and get a referral for the isolation facility.
I don't know if Stephanie or Adrienne are still on. They can contact 311 and we can get them connected. That's probably the best way.
Great, thank you. And I would just ask our PIO if they're listening that we figure out how to make that clear on the city website. What somebody should do if they're in need of that isolation facility. Thanks again.
Councilmember Ellis.
Shorter, I really appreciate you being able to give us that update about the Parks and Recreation Department. And I would ask that other park spaces that are being used similarly to non-chlorinated pools should be looked at and identified in that too. I think the same precautions we're trying to prevent with non-chlorinated pools like Deep Eddy or Barton Springs, we're having the exact same issues in other places. I know there's not many where we actually have a lot of water right now for people to congregate, but I think those areas need to be identified and included as well.
Thank you, Councilmember.
Okay, colleagues, we ready to go to executive session?
One quick one, Mayor.
Yes.
So Dr. Escott, thank you for letting us know that we should start saying, if you don't have insurance, the public sites are for you, because we're having to ration those, and I know you're trying to ramp that up as fast as we can. And that if you have insurance to go with private folks, you had mentioned that if you do have insurance, it's free. But I've seen a lot of reporting, including in the New York Times today, about Austin residents going to a private place and still winding up with a big bill. Is there anything we need to know about that? Is there any information we should be giving people to handle that?
Yeah, so, and folks needed to do a little homework to find out what the other charges are. So the test itself is free and covered by insurance without a deductible. But the visit, if they're going to a clinic and they need to see a physician or a nurse practitioner, there may be a charge for that visit. Certainly, if they're going to an emergency room, there is going to be an ER bill that comes with that test. So ERs are not the place to go to just for the purpose of testing. If you think you have a severe illness, if you're short of breath, have chest pain, you're lightheaded, you're dehydrated, that may be the place you need to go, but not if you just want to get a test done. That's going to come with a big bill. That's true for the ERs at the hospitals. It's true for the freestanding ERs. So call ahead and check on that. I think there's more and more facilities offering testing every day. And as Director Hayden said, we'll have a map soon about that. We're seeing more pharmacies like CVS and Walgreens, and in the future, grocery stores and others that will have testing. And that's why I said earlier, at some stage, APH is going to diminish as those other entities take on more responsibility for testing. And quite frankly, when it's closer to home and it's convenient, people are going to do it more easily with fewer barriers, particularly if they can do that in a cost-effective or free way.
Thank you.
Okay, colleagues, ready?
Mayor,
I want to thank, I'm sorry.
I was just going to say probably the same thank you, but just really appreciate your leadership, Mayor, and the entire leadership of our council. It is more critical than ever that we are united as one community, one city to tackle this pandemic. And I'm just so proud of the work that we're doing and the incredible work of our public health professionals. So I don't think we're coming back in a public setting. And so I just wanted to say that out loud. Really appreciate everyone's support. I
appreciate that. And the amount of time that Austin Public Health is spending, Director Hayden, Adrian Stirrup, the Dr. Escott, but it's everybody. It's the communications team. It's the EOC Center. These are our people that have been like on emergency duty now going on 3 months. And I just want to thank everybody, both in the city and with the county. It's been a real pleasure working with Sarah Eckhart, before she was judged, now not, who's also been putting in that amount of time. It's great to welcome Judge Bisco involved. And I would just close with the last thought, if we're reinforcing public messaging, that this really is crunch time for the city. This is crunch time. This is where our individual actions will add up to a community action and determine whether or not we're able to keep businesses open, whether we're able to go to schools, open schools in the fall, whether we can protect people and save lives. And at this point right now, where we sit right now, it's really going to take everybody in our community deciding without order, without repercussion, without penalty. This has got to be the time when our businesses and our individuals do what is necessary to protect and support the community. And I hope that we make the choice to do that. Masking and social distancing. No large groups. Don't go out if you're sick. Stay home if you can. It's the safest place you can be. And with that,